Thank you, everybody, for being here. I'm greatly honored to be moderating this session, and thank you. As we've heard, we are living longer, but what that means is we're living with multiple chronic conditions that was mentioned in a disease-centric health system and world. Our treatments have evolved. There are a lot of more options to treat many diseases that we've never faced and our generation has never seen before. And also hospitalizations are shorter and care is being brought into the home and in the community. So really, as a society, we are relying on family caregivers and some formal caregivers as well if you're able to get them. So caregiving is an essential part of a successful care plan and health outcome. So thank you for being here. Can you briefly introduce yourselves?
Good morning, everybody. I'm Ian Kramer. I'm Executive Director of the LEAD Coalition. We are a coalition of approximately 260 member and allied organizations working on federal policy to improve quality of life for people with dementia, reduce risk for dementia, and ultimately try to cure all causes of dementia.
Good morning, I'm Tom Eads. I am a geriatrician. I am currently Senior Medical Advisor for Geriatrics and Extended Care for the U.S. Department of Veterans Affairs. I have focused my career on improving the care for persons with serious chronic disabling diseases and wherever possible, move that care into the home. And I mean all care, urgent care, hospital care, nursing home care, primary care. I have been the Executive Director of all geriatrics and extended care and palliative care services for the Department of Veterans Affairs, and VA has given me a phenomenal opportunity to learn and collaborate and grow with all of you. Thank you.
Hi, everyone. My name is Purvi Bhatt. I am the incoming interim CEO of the Rosalind Carter Institute for Caregivers. Most importantly, I'm a second-generation Indian American. And I took care of both of my parents, who were first gen, who arrived in the early 1960s, pre-civil rights, Harshad and Rekha Bhatt. They died in their 70s. My father had early onset dementia when I was 28, and he was 58. My mother died of a fifth cancer. The first one was when I was 3, which made me an only child. I say that because we're here, and everyone in this room has some story that's very similar to that, so I wanted to take that opportunity. I'll end on this today. Melinda Gates has taken the opportunity to lift up 2 organizations, mine being one, the Rosalind Carter Institute. Why? Because she's using her name, her power, and Mrs. Carter's legacy to lift up the fact that we're all trying to take care of everyone that we're here for today. And to democratize that experience. So I just wanted to lift that up. It's a proud moment for us in living our legacy, but it's more important that it's allowing all of us to come out of hiding and appreciate that we're taking care of each other.
Great. A few data points. Nearly 70% of family caregivers are women, but that's changing. More and more trend are male family caregivers. Most family caregivers are also working at the same time of providing care to loved ones. And many are providing care for an adult as well as children in the sandwich generation. And then I want to just, before we jump in, say we often talk about caregiving as a burden, but there's an opportunity to be a positive experience, a healing experience, and purposeful experience for many, and that's our goal. So we have an amazing panel. The invisible workforce, the critical role of caregivers. Purvi, what's the real issue here with caregivers? What are family caregivers facing? And what is the challenge they see?
Yeah, well, thank you for the question. There are many. First of all, I think it's really important to link in what we've been hearing over the last 2 panels. Hidden in plain sight, time, connection, which we haven't really talked about. We are in the middle of an isolation pandemic. So hidden in plain sight, not enough time, and not able to connect. Not really a burden if you're allowed to actually use time the way you want to use it. And on top of everything else, if you've paid attention to the CDC MMWR, at the end of August it was reported that 13 out of the 19 health indicators that were reviewed in a recent study, caregivers, family caregivers, when compared to non-caregivers, were disproportionately worse in their health. Taking care, the act of caregiving, has now become a determinant of health, a positive one for the care recipient, a challenging one for those of us that are taking care. So the issue in front of us is not the workforce part. That's probably the biggest problem, is being viewed as the workforce. We are not. We are here to fill in so many things because we want to and we need to, as neighbors, as family members, as friends, as many of us will age on our own. It will be more than just an obligation or a duty. And if you happen to be an immigrant, a person of color, really trying to fit in the health system, we already heard that in our prior panel, it's time that a lot of the rub starts to soften and figuring out how we can come together. I'll end on this. I already told you 13 out of the 19 health statistics are worse for us. 1 out of 5 women drop out of the workforce to take care of a parent. Every year that she drops out is $300,000 lost in her retirement savings. There are others here who will know those data points even better. That has to change. Otherwise, we are doubling down on refueling something that is a greater pressure economically and to our health system. And it's going to be the social issues that will help us in the end. My next door neighbor is 100 years old. Her next door neighbor is a former senator and his wife that are 95 and 96. They take care of me because they make sure I got home okay. So this interconnectedness, which is culturally a part of all of what we do, is important. And the final thing I'll say is this is a cultural issue. You go into anyone's home, as we're looking at aging in place, hospital at home, all of the things at home, doesn't matter what part of the world you're from, by definition, you've entered someone else's culture. We have to be a little more flexible in how we do that and how we design that together.
But caregiving has also changed over the last several decades. How has it changed? Medically, infusions? Can you describe what people are seeing?
Well, so I think it's changed in a number of ways. In part, it's resources, but to Porvi's point, not equitably distributed. And even for those of us who experience enormous privilege, both in and outside the healthcare system, not necessarily evolving in terms of awareness of those resources and how to best utilize them. And I've been working in dementia for 28 years. There's a lot I don't know. I'm not a clinician, I'm not a researcher, I'm in the policy space, but it affords me a lot of connections. And yet it doesn't necessarily afford me all the perspective and insight about the resources that are available or were available to me through my 5 years of being the primary family caregiver for my father, who had multiple chronic conditions for most of his life, but in the last years of his life also had cognitive impairment descending upon him. And I'll give an example, practical example of how it can work better. I was fortunate, among other things, to have an extraordinarily capable and caring primary care physician who understood that as a family caregiver, who on top of a self-imposed 80-hour-a-week work lifestyle, also was intensely involved in my father's well-being. And this primary care physician, always asked after my health and how I was coping and what he could do to support me as best possible under extraordinarily difficult circumstances, to sleep better, not necessarily right, but better, eat better, deal with depression and other mental health threats. Mercifully, I was not one that had to endure full-blown official depression, but there is a toll emotionally. But to treat me like part of my care was looking after me in my caregiver or care partner role. That's something that is not available to the vast majority of care partners, and most care partners don't know to ask their primary care physician to consider their caregiving role as part of their overall health picture. It can happen, it should happen. I was lucky it happened for me. That should happen for every care partner, one who self-identifies with that label, or even if they don't know what to call themselves, but they know they're supporting a loved one, particularly an aging loved one.
A great point. While we as a healthcare system in the United States are relying on family caregivers to implement our care plans, they're the invisible workforce, but they're also the invisible patient, and we need to acknowledge that. So thank you for that point.
I want to add to one point of that, and think about the demographics in our country. The numbers of potential family caregivers for each individual who will likely need that care is diminishing. Numbers look at 7 down to 4. So the numbers available for a family caregiver is diminishing. At the same time, most of us are living longer with serious chronic diseases and will be more reliant on caregivers. So this is a huge challenge for us to face.
Tom, at the VA, you have created across the nation some incredible innovative programs that are clinical programs that help patients but also help caregivers. Can you describe what the VA has done?
Sure. VA is under intense pressure. We, as a mission-driven organization serving veterans who have served for all of us, for our freedoms, we're constantly driving for innovation. What can we do to improve the care and outcomes of veterans? And we also know that many of those veterans are relying on family caregivers. So VA has come up with some innovative programs. I think I'll put those into 3 categories. It may be a framework that's helpful to all of us as we work together to improve the situation. So one category is stipend. Do we pay caregivers? Since 2010, Congress approved a move for us to treat a sector of the population. It was mostly seriously injured veterans coming back from Afghanistan and Iraq. And the criteria were developed so that some of those family caregivers who were going to spend an inordinate amount of time trying to take care of this person who's come back from war, a stipend, as well as the supportive services that we put in other categories. And so, but that was a confined group and a stipend. We've learned from that, from a few hundred to now many more. We've expanded the eras. It's not just that group anymore. So that's one category, and it includes a stipend to caregivers, which I think is an important model for us to examine and look at. Another one is the general caregiver support services. And so that's some things like, and that's for all veterans enrolled in VA for healthcare. They're all eligible for that. Oh, and I didn't mention service connection in that stipend group. They have to, their injury or condition had to be deemed as service connected. So it was a confined group. In the caregivers for, support for all enrolled veterans, there's no requirement for a service-connected condition, so it's available to all of them. And it's things like inpatient respite for the caregiver, home respite for the caregiver, programs like adult day health care, like home health aid. One of the differences in VA is that we will offer to provide home health aid services for those who need it, and that often provides respite to the caregiver, and it's not requiring a skilled nursing, there's no skilled nursing requirement. Because from our perspective, many of these people have this condition for years. It's not going to go away. They don't have a skilled need consistently at all, but they do need home health aid, so we provide that. I want to mention home-based primary care in the VA, a program that has been under my responsibility for several years. And it's comprehensive. It's very different from and complementary to Medicare home care. It's comprehensive. We take care of all of your problems, not one or two. It's longitudinal. Your conditions, your multiple conditions are not likely to go away or get better. We're going to probably take care of you this way for the rest of your life. It's interdisciplinary. And we know that that's a foundation. It's just focused on that veteran, but we know that the family caregiver is very often crucial in that veteran being able to remain at home. But I want to say that many times those family caregivers tell us, oh, I never would have been able to do this. I never would have been able to provide this care to keep this loved one at home if it weren't for home-based primary care. So we do play a role in that. We're supporting them in many ways. We link up with services that they need. We provide education and training. We recognize their caregivers. We appreciate them. We help them training for some of the maybe behaviors that they're going to need to deal with or other things that they'll do. So it is a foundational part. The third, one other thing is innovation. There was an entity called, it was a research model that is still very active. It was called REACH, and it's resources to enhance, and originally resources to enhance Alzheimer's caregivers' health. And I want to recognize the Rosalind Carter Institute because they recognized in 2008 our role. And I and the home-based primary care team and the researchers, Linda Nichols and Jennifer Adams at Martindale at Memphis, were the co-recipients of a Rosalind Carter Leadership in Caregiving Award for moving moving research into practice. And the third category is what about the many people, and so I'll speak about veterans, who we've been supporting. They live alone, they're progressing as they get older, they have more conditions, more needs. We've built the ramp because you're now in a wheelchair. We're providing home health aid. We're surrounding you with home-based primary care, but it's not enough.
Right.
It's not safe for you to live at home any longer. Now, they could live safely at home if they had a strong family caregiver, because family caregivers do amazing things, but they don't have one.
There's a growing population of individuals that are aging alone. Our system of healthcare delivery is based on family caregiving. That's our social care. But there's a growing population that don't have family caregivers.
Right. And so we had a couple of social workers, brilliant social workers, who came up with a model for this, and it's called the VA Medical Foster Home Program. It was a pilot under me in around 2000. But what they do is they find someone in the community who's willing to open up their home and heart and take in a veteran, 1, 2, or 3. So this veteran will move into a personal home. This is the home of that caregiver. And it's an amazing program, and a foundational part of that is home-based primary care, because we surround them. Now we're bringing care to the home, we're supporting that caregiver, and this is one of the reasons why it's really important that we strengthen the home-based primary care economic situation out beyond VA, so that more people, more of our clinicians and teams can provide this kind of care. And if we have a strong home-based primary care foundation across the country, then all Americans will be able to, we will be able to provide that kind of medical foster home model to everyone.
Thank you. Rosalind Carter Institute for Caregivers. Rosalind Carter had a famous quote: "There are only 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers." Ian.
I'll take being called Tom. He's pretty good.
As Executive Director for LEAD, a dementia-based founded organization, what can we as health leaders, what is our call to action? What is public policy we should be advocating for? And then I'll ask the others to join in.
Sure. So I literally have a list of over 500 things, but it's not my list. So there's a project of the federal government led by the Administration for Community Living around support for caregivers and trying to identify policy opportunities for both the public and private sector, and in the public sector, federal, state, and local. Some are done individually by specific agencies like VA, some may be done by specific nonprofits like RCI. Many are opportunities for collaboration, and this national strategy around around family caregiving has over 500 action items, many of which are well underway, none of which I think we could fairly say are completed because the work is ongoing and must be ongoing. So I would direct everyone's attention to the national strategy and suggest that every organization represented in this room and online, and all of our partners across the country and around the world, should look at those strategies. And you don't have to do all 500, but pick a handful that fit with your strategic plan, your mission, your values, your priorities, your budget. I will give you a few concrete examples, and I think you said I have a half hour to go through my list. But, happy to talk with anyone after, but just to give a few examples. Some of you are aware that there's a thing called the Older Americans Act. Double the funding today, and you would still not meet all the need. So one of the most infuriating things for family care partners and those who support them, organizationally and individually, is to know that the individual is eligible for supports and no supports are available because the money isn't there. We can have the conversation about the economics of expanding the budget for these various federal programs, Older Americans Act, VA, others. I will tell you, 10 times out of 10, it's going to be a win-win from both a budgetary and an economic perspective. Oh, and by the way, it's the right moral and ethical thing to do. But please, for God's sake, don't tell people they're eligible and then tell them that there's an 8-year wait list. Dr. Reverend made this point about housing. The same would apply for respite services, transportation, home-delivered meals, respite care, in-home aid support, and on down the list. Don't change the eligibility criteria to reduce eligibility to eliminate the wait lists. Get rid of the wait lists by expanding the availability of services. And oh, by the way, lead with health equity. Deliver those services, expand the availability of the services where the services are going to make the biggest impact on those who have been most marginalized, not just in the current day, but historically and today and sadly moving into the future. So begin where the problems and the opportunities for progress and for return on investment, budgetary, economic, moral, and ethical return on investment are greatest. A couple more practical examples, and then I promise I'll maybe not physically turn off my microphone, but at least functionally do it. There are specific programs in the Alzheimer's and disease world that are frankly no-brainers, and we ought to be expanding them right away and extending them to other communities. And one example launched about a year ago, or announced about a year and a half ago and launched last summer, is called the GUIDE model. And I won't bother you with spelling out the acronym, but the gist of it is, much like the VA already does in many cases, coordinated, I won't say comprehensive, but coordinated care for families that are dealing with dementia. So it supports not only the person that in a medicalized world we call the patient, but also in a very tangible, organized, cohesive, and resource-intensive way with results to match, supports the family care partner or partners with things like a respite subsidy, a 24-hour, 365-day-a-year accessible care navigator, just like we have in diabetes. We need that in dementia, maybe even more so, and a variety of educational resources. The aspiration of the Center for Medicare and Medicaid Services Innovation Center is to serve as many as 200,000 people over the next 8 years. Today, there are 7 million people living with dementia in this country. So 200,000 is 200,000 more than were served before the program is launched. We're all grateful for those 200,000 families getting help. It doesn't do anything for the other 6.8 million today, and those numbers are growing over the next 8 years. So we ought to radically expand the availability of the GUIDE model during these 8 years, learn more, move faster, reach a decision more quickly about whether this becomes a full-on Medicare benefit or not, and we should expand it to other disease states, not least of all because people with dementia don't just have dementia, they tend to have at least 5 chronic conditions. So we can do better, we must do better, we can afford to do better, and we can't afford to not do better.
And acknowledging the dementia when we're addressing the other chronic conditions, it's just a small step to address, because it complicates the treatment and the outcomes of the other diseases. Any other public policy?
Yeah, I can jump in on that. I think there's 3. So we've got an amazing opportunity with the strategy that's in front of us. It's 500 actions. There's an important opportunity to coordinate and collaborate, noting that there are resources that exist, but getting efficient about it so that it's easier for all of us is a big part of that. So making sure that that's there. The second is, we all know as caregivers, and we all know the people that we're helping to take care of have multiple conditions. We've worked with Duke University to and poured over 10,000 papers and qualitative information to be able to clearly identify 10 different profiles from the family caregiver perspective, irrespective of the disease state of the people that they're taking care of. Connecting up to that and starting to look at what is really happening for the family caregiver in this process might help us interrupt the next disparity that's coming up, which is, are you a caregiver or are you not? So that's the second one. The third one is making sure that as we're designing for all of the things that we're planning on, bringing care home, ensuring things like hospice are actually culturally appropriate. Respite is often not trusted because of the things that it takes to let go. All of that requires that we start with the family caregiver in the design process, not assuming it. And we're all patients sitting here, and we're all caregivers sitting here. So we are able to put that hat on as we're in the design process as well, and as decision makers, but independent of that, the next time there's time to think through what should we be doing, there's a seat at the table, at least 3, for family caregiver perspective.
Great. I want to thank all of you for being here. So if I heard, let's acknowledge the family caregiver. Let's acknowledge their work as well as them as a patient here, because if they're healthy, our patients are healthy and the care plan can be done, and advocate for the Older Americans Act to be refinanced and increase finances, and look at the strategy that's been developed. Thank you very much.